Welcome. Today we'd like to talk about radiation safety information for low-dose medical imaging that utilizes ionizing radiation. The term safety is very subjective, and it often means absolute safety, so we rarely use it when we're talking about ionizing radiation and the risk of biological damage from ionizing radiation. Safety is subjective. A knowledge and understanding of the risk of ionizing radiation exposure is important when looking at the biological safety of utilizing ionizing radiation in medical imaging. Here we see the generation of ionizing radiation for X-ray. We have two primary types of interactions that are happening during the ionization of the atoms. One is called the photoelectric effect and the other Bremsstrahlung. We all learn this in our basic courses in radiography. Primary ionizing radiation does not change. It is merely one part of the term used overall as radiation. For in radiation, we have ionizing and non-ionizing radiation. To create medical images, we use both ionizing and non-ionizing radiation. Basically, what we are doing is recording the interaction of energy with tissue and taking that interaction and transforming it to an image that we can diagnose. We make medical imaging from all kinds of energy. We use ionizing radiation and non-ionizing radiation for a majority of the exams. The use of medical imaging is rising, and approximately 3.3 billion of the 5 billion imaging examinations performed worldwide use ionizing radiation. Thus, diagnostic imaging contributes to most of the artificial radiation exposure to human beings. What many people think of as an art in medicine is the ability to make a diagnosis. Medical imaging is a primary component of patient diagnosis. In medical imaging, we have two primary manners in which we can create medical images. One would be the photographic process, and two, the digital imaging process. We have evolved from the 1800s using the photographic process to strictly digital imaging processing today. Here we see a monument to Professor Henry L. Smith, who pioneered medical imaging uses for X-rays. Notice these studies were done in February 1896 in a nearby lab. We have evolved a lot in scientific and technical knowledge since 1896, but the basis or the primary methodology of recording imaging is using diagnostic, ionizing, and non-ionizing radiation to create the images. All images that are used for medical imaging are acquired from the recording of energy interactions with tissue. Ionizing radiation is only one form of energy that we utilize in medical imaging. It is critical to understand the type of energy being utilized, the amount of energy being utilized, and the time the energy is being utilized to create an image. We can call this the dose. When discussing ionizing radiation, we can talk about high dose and low dose. Well, what's the difference? Low dose is basically harmless and used for medical imaging. High dose actually interacts with tissue and destroys biologically the tissue. Although the ionizing radiation is the same, there is a large difference between using low dose and high dose ionizing radiation. Let's take a look at creating a digital imaging. First, we have an analog signal or energy that must interact with the tissue that we are trying to analyze. The quantity and the intensity of the signal is defined by the technical factors in creating the signal. The tissue absorbs the energy from the signal. It then emits a signal that demonstrates the interaction of this process. In medical imaging, physicians utilize analog signals, or they utilize images that they can see to diagnose different types of disease and decide on different types of therapies that can be utilized in treating that disease. Visible light, or the signal that they look at, is part of the electromagnetic spectrum and is an analog signal. So let's take a look at the process from the first step to the end step. In the first step, we are going to take energy and have that energy interact with tissues of the body. That interaction is then recorded, or the intensity of the interactions are recorded. And the recording is then transformed from an analog signal to a digital signal. This digital signal is then utilized to create an image for diagnosis, selecting the data that we want to visualize. But we cannot visualize data or numbers. We have to visualize an image. So we need to change our digital data back to an analog signal, which is visible light, or the image that we look at. We use different types of energies or signals to interact with tissue to make an image for diagnosis. Most of that energy is found on what is called the electromagnetic spectrum. And on the electromagnetic spectrum, we have ionizing radiation and non-ionizing radiation. The difference being that non-ionizing radiation is of lower intensity and does not affect the tissues other than heating, whereas ionizing radiation can actually affect the cells and the DNA in the tissue, creating biological damage. Gamma radiation is used in nuclear medicine, SPECT, and positron emission tomography, and molecular imaging, and this is an ionizing radiation. Sound waves are used for sonography, Doppler ultrasound, and molecular imaging. This is non-ionizing radiation. Radiofrequency signals come from magnetic resonance imaging and molecular imaging. And these, again, are non-ionization. The one portion that the public and the occupational worker is mostly aware of is X-ray, which is a portion of the ionizing radiation spectrum on the electrical medical imaging spectrum. The use of X-ray to create images can cause damage to the tissue. Does interaction with X-ray cause damage? Either gamma or X-ray, both are ionizing radiations that can cause damage. It is the dose or the amount or intensity of the signal that creates the damage. In most cases, we have no strength or energy in the diagnostic imaging range that can cause damage, whereas in the radiation therapy range, the intensity of the signal, although it's still the same ionizing radiation, is such that it can damage tissues. So we look at low dose and high dose. Low doses of ionizing radiations used for medical imaging are generally harmless. High doses of radiation used for radiation therapy are harmful to tissue. And what is the difference? The energy. Remember, when we set our exposure factors in medical imaging, we use KeV, EV being the energy or electron volt, and it's measured in thousands. When we use radiation therapy, we use MeV, or electron volts used in millions, where there is a distinct difference in the strength of the signal and the amount of damage that can be done by the signal. Time is also a factor in exposure. Well, this presentation is about radiation safety, so after getting some of the background, let's take a look at who is responsible for your occupational radiation dose that you receive. And really, there are only two people responsible for your occupational dose. That is the equipment operator, whether they're a technologist or a physician, and you. The equipment operator controls the dose or exposure, which is the amount of radiation utilized, the area of exposure, and the number of exposures required to create the data to make the medical images for study. To create medical images, we use remnant radiation. Remnant radiation is the radiation that is emitted after the patient is exposed. In remnant radiation, we have the photoelectric effect, and we have scatter radiation. Scatter radiation is rather useless, and the majority of the emissions actually are scatter radiation. It is the direct interaction or photoelectric effect and Bremsstrahlung effect that we look at in creating data for medical images. Remember that in dealing with this topic of radiation safety, this presentation presents topics that have some theoretical considerations which have been greatly simplified. This is especially true of the concepts in physics. The technical aspects of imaging, which have been greatly simplified here, only serve to facilitate the understanding of the digital imaging process. The aim here is not in-depth technical expertise, but the understanding of key concepts related to ionizing radiation exposure. All imaging modalities emit and acquire analog signals from the interaction of energy with tissue, which are used to create images. Image quality depends only on the intrinsic or objective physical characteristics of an imaging system and can be measured independently by the observer. Image quality is whatever the observer says it is. It is a subjective perception of the image, or as we often say, beauty is in the eye of the beholder. Image quality is defined by an observer's ability to achieve an acceptable level of performance for a specified task. Today, all forms of images are included in medical imaging, whether an MRI or a photograph or a diagnostic X-ray. A digital image is not an exact picture of reality. It is only a discrete approximation based upon the data capture and the software construction of the energy interaction at a specific time with a specific tissue. The modality used and the exposure technique and the region of interest demonstrated determine the data that is captured. How the data is displayed and manipulated or imaged depends on the information requested by the viewer. The same data can be reviewed many times and displayed in many different formats. The process of capturing the data, understanding the data, and manipulating the data to create an image is different for each modality. Digital medical imaging is indirect and often counterintuitive. Image visualization refers to all types of manipulation of the captured data matrix resulting in an optimized output of the image. In other words, we select what we want to see. A software routine that changes the appearance of an image or part of an image by altering the pixels of the matrix of the acquired data is how we manipulate the data in the image. Filters are used to increase brightness and contrast as well as to aid or add a wide variety of viewing enhancements. Before we progress, let's take a look at some of the learning objectives for this section of the presentation. What are the federal and state entities responsible for low-dose medical imaging using ionizing radiation? What is the difference between ionizing radiation and non-ionizing radiation? What is the difference between low-dose and high-dose ionizing radiation? Which type of ionizing radiation can be biologically damaging? What is the difference between patient dose and occupational dose of ionizing radiation? Explain what risk versus benefits means. Discuss the role of probability when referring to ordering patient exams and safety. Explain how ionizing radiation may cause biological damage or cancer. How is dose for radiation monitoring of patients and occupational workers recorded? Relate the details of a traditional radiation safety program. Explain the exposure risk for patients and occupational workers associated with exposure to ionizing radiation. Discuss the role of dose when comparing low-dose and high-dose ionizing radiation. Compare the risk for patients and occupational staff and the threat of being exposed to ionizing radiation. And finally, relate the purpose of time, distance, and shielding and the protection from ionizing radiation. Who is actually responsible, either the federal government or state agency, regarding the use of occupational radiation and occupational radiation protection in the United States? It would appear that it should be standardized. But is it? Briefly, the Nuclear Regulatory Commission, NRC, regulates exposure to radioactive materials. OSHA requires employers to protect workers from exposure to ionizing radiation sources that are not regulated by the NRC or other federal agencies, such as equipment, some accelerators, incidental accelerator-produced radioactive materials, ion implanters, and some naturally occurring radioactive material. States also regulate exposure to ionizing radiation in conjunction with the NRC. The NRC has 28 states which are known as agreement states, and they basically are regulating the ionizing radiation exposures under the auspices of the NRC. These states may also regulate occupational radiation exposures that the NRC does not. The difference is that each state has its own policies and procedures and regulations. And these policies and procedures and regulations, at the minimum, must reflect the policies and procedures of regulations expected by the Nuclear Regulatory Commission, but not limited to those. Each state can have more stringent policies and procedures towards occupational radiation protection control. And if you are creating a worker safety program, you need to understand what the parameters are in your state for occupational radiation safety protection. We have 50 states and a number of territories. Most states have a radiation control agency responsible for regulating radiation-producing machines, and, if also an NRC agreement state, radioactive materials. Some states regulate occupational exposure to ionizing radiation, in part through licensing and certification of medical imaging and radiation therapy professionals. Some states may also limit worker exposure to radiation differently than OSHA. For example, many states and the Department of Energy and the NRC have cumulated annual dose limits that differ. State plans are required to have standards that are at least effective as those of the federal agency NRC and OSHA. The bottom line is that there is actually minimal regulation for the use of ionizing radiation in the United States that is standardized. OSHA is the federal agency for the Occupational Safety and Health Administration that covers ionizing radiation. OSHA standards cover all workers in the private sector as well as employees of most federal entities. State and local government employees are covered if they are in one of the 28 states and 2 territories that operate their own OSHA-approved state plans. The federal government exempts some workers, such as military employees, from having to adhere to the standards of the NRC and OSHA. One of my favorite sayings relates to theory and reality. The saying is simply that in theory, theory and reality are the same, but in reality, they are not. This saying is especially apropos when talking about radiation safety and how and why we utilize radiation or ionizing radiation in the medical industry. In theory, ionizing radiation should be standardized, the use of ionizing radiation should be standardized, and the licensure of people that utilize equipment that creates ionizing radiation should be standardized. In reality, they are not standardized. In most cases, the benefits of indicated medical imaging will outweigh the relatively small excess cancer risk associated with the procedure. Patient management should not be altered based on radiation risk. However, for certain subsets of patients, radiation risk should be of greater concern to the clinician. Damage from low-dose ionizing radiation should be taken into consideration, and you need to look at the probability or the measure of the likelihood of an event occurring which can damage tissue or even cause cancer. Many events cannot be predicted with total certainty. We can predict only the chance of an event occurring and how likely that chance is of happening. The chance of radiation damage from low-dose ionizing radiation damage is very minimal unless we have something like a invasive procedure with fluoroscopy where the physician uses way too much radiation for the procedure. Radiation dose from an imaging study can be reduced by 3 methods. First, one can decide not to perform the study at all. Such a decision should be based on proper understanding of the indications for the study in the first place, review of any previous imaging that might have already answered the question, and an assessment of any special patient considerations that increase or decrease the risk from exposure. Second, an alternative study that does not use ionizing radiation can be selected. And third, the less radiation can be used to create the images. In other words, we can manipulate the exposure factors to utilize the minimum amount of radiation to get the information that we need. The question we'd all like to have answered is, can radiation cause cancer and damage to cells? The answer, unfortunately, is yes and no. Ionizing radiation is a form of radiation that has enough energy to potentially cause damage to DNA, and we can use either high dose or low dose ionizing radiation to create images. So what is the probability of diagnostic imaging energy causing cancer? Well, when we say that the probability of 1 photon of ionizing energy when interacting with human tissue can cause cancer, that statement should be similar to saying there is a probability of a person getting cancer from 1 minute of their lifetime exposure to the ionizing radiation from the sun. Both are theoretically possible, but what is an individual's chance of getting radiation cancer from either of these finite statements? For radiation safety for both patient and occupational workers, we need a proper perspective of what the safety issues are and how to prevent any type of accidents. Here we're going to see how cancer can be caused from ionizing radiation exposure to a cell. But remember, that cell has the ability to repair itself. So this is a probability of an event happening. When ionizing radiation strikes the cell, it excites the atom inside the cell, and it actually ejects energy or an electron from the atom cell. This energy interacts with our DNA, and if it breaks both strands of DNA at the same level, which is a very low probability, we could cause a cancer cell to be created. That cancer cell can grow, of course, over time and may even metastasize. Obviously, large doses of radiation can cause extensive cellular damage and even result in cell death. Remember, if the cell dies, we do not have a cancer created. It is only if the cell mutates. When smaller doses, the person or particular irradiated organ may survive, but the cells are damaged. This increases the chance of cancer. The extent of the damage depends on the total amount of energy absorbed, the time period and dose and rate of exposure, and the particular tissues being exposed. Luckily for us, to counter cellular level mutations, the human body has active repair processes. although these processes are not entirely error-free, and their relevance to human cancer risk remains unclear. Should a radiation cause cancer develop on one or more cells, the process may take years and the source of the cancer will be verifiable only in an exceptional case, given the current limited understanding of how cancer develops. Although certain cancers are associated with certain types of mutations, like breast cancer with bone, brain, liver, and lung. Although nearly 1 in 4 persons in the United States dies of cancer from all causes, low-level radiation presumably accounts for a very, very small fraction of these cancers, if any at all. However, the fraction cannot be quantified. The adaptive response systems very efficiently prevent, repair, or remove virtually all DNA alterations caused by the ionizing radiation. It is extremely unlikely that patients or staff will receive any harm from low-dose ionizing radiation. Should traditional radiation safety programs be updated, eliminating outdated data, policy and procedures, and changed to reflect current radiation protection practice and information? The obvious answer is yes. So let's take a look at a traditional radiation safety program. This may cause some concern because after teaching radiology and medical imaging for a number of years, it was the basis for most of our radiation protection, the linear non-threshold dose model. If you take a look currently, the CDC says that this model was flawed and outdated in its use. Now, take a look at the list of occupations that actually are related to occupational exposure to ionizing radiation to the right. You'll notice that everything from medical imaging to being a TSA person is included in this list. Everything from being a nuclear physicist and scientist down to being an X-ray tech is included in this list. Go through the list and see what you think about the occupational exposure associated with each of these professions. Now for the part that confuses both healthcare professionals and the public about ionizing radiation, and even is confusing to some occupational workers. There are different environments in which ionizing radiation is used, and different occupations using ionizing radiation. Therefore, we need to have an overall minimum standard based upon the ionizing radiation's effect upon human beings. Just as the measurement of foot and meters is different in the traditional system and the international system, so is the measurement of ionizing radiation. In the traditional system, we use the Rinkin, the Rad, the Rem, and the Curie. In the international system, we use a metric system of the sievert, the Gray, and the amount of radiation exposure in air. The real confusion starts when we try to correlate all these different terminologies and integrate all the information so they're standardized. And this, again, causes some problems. Let's take a look at the occupational guidelines to demonstrate what I'm talking about. No employer shall possess, use, or transfer sources of ionizing radiation in such a manner as to cause any individual in a restricted area to receive, in any period of 1 calendar quarter from the sources in the employer's possession and control, a dose in excess of the following limits. Whole body dose, which is the head, trunk, and active blood-forming organs of the lens of the eyes or gonads, 1.25 rem per quarter. Hands and forearm, feet, and ankles would be 18.75 rem per quarter. Skin of the whole body is 7.5 rems per quarter. In simple terms, different tissues have different radiation sensitivity. The more sensitive the tissue, the less radiation the occupational worker can receive in that area. We usually divide it out by whole body, hands and forearms, and the skin. We'll talk in more detail about the term REM in the next following slides. An employer may permit an individual in a restricted area to receive doses to the whole body greater than those permitted above, so long as they're during any calendar quarter. The dose to the whole body shall not exceed 3 REMs. And the dose to the whole body shall not exceed 5 times the patient's age minus 18 times the number of REMs. No employer shall permit any employee under 18 years of age to receive any period of 1 calendar quarter a dose in excess of 10% of the limits specified in the bulletin points above. So what we're looking at is there's a total difference between working in a nuclear radiation plant, medical imaging, and working with mining of radioactive materials. And to that end, there are different standards. The occupational dose is very difficult to understand if you take a look at it as a whole. When we talk about the occupational dose for medical imaging, which is low dose, we can pretty much say that we are looking at a total of 50 millisieverts per year whole body radiation as a limit. Medical exposure differs from occupational and public exposure in that persons, primarily patients, are deliberately and knowingly exposed to radiation for their benefit. In medical exposure, applying a dose limit is inappropriate, as it may limit the benefit for the patient. Consequently, only 2 of the radiation protection principles apply: justification and optimization. An easy way to look at this is that if you're getting radiation therapy to cure your cancer, you're going to get a larger dose than if you're getting an X-ray of your chest to see if you might have cancer. Often the most difficult aspect of obtaining an X-ray imaging study is convincing people that the study is warranted and that the risk outweighs the benefits, because we focus on the risks of ionizing radiations and not the positive that is resulting from the examination. Here's a practical example of risk versus benefits. Here we have a child that needs a CT scan prior to surgery. We will see that if 1 million children get CT scans, there is a possibility that 100 will have a risk of getting cancer. That is simply a possibility. That does not mean that all 100 of them get cancer. But this is what the person usually looks at. They don't look at the aspect saying, if we don't say that 1 million kids receive CT scans, half of them will avoid unnecessary surgery. 100,000 of them will receive surgery that is better because a surgeon is guided by the CT results, and 300,000 of them won't have to go to the hospital for unnecessary surgery. Big difference in what we perceive and reality. We'll now concentrate on radiation safety from the perspective of diagnostic medical imaging. Medical imaging can use radiation to create medical images. Radiation can be divided into 2 categories: ionizing radiation and non-ionizing radiation. When we look at this, we think of radiation as being energy. So we're looking at the energy which cannot ionize an atom. This is non-ionizing radiation. and radiation whose energy is so high that it can ionize an atom. When it ionizes an atom, it changes the structure temporarily. And this can result in a mutation. We also need to look at the perspective of low dose versus high dose ionizing radiation. Obviously, the more radiation you receive, the higher the probability that there will be damage. And the lower the dose you receive, the probability is that the exam is totally safe. Ionization is energy that is in the form of a particle or a wave. Non-ionizing radiation is in the wave form only. Take a moment to look at this diagram of ionizing and non-ionizing radiation, and then we will continue. We'll now look at the electromagnetic wavelengths of the electromagnetic spectrum and particles that comprise ionizing radiation and non-ionizing radiation. Part of the electromagnetic spectrum are radio waves, microwaves, infrared, visible light, ultraviolet. Ultraviolet is also part of the ionizing radiation level of wavelength. So when we're looking at this, we're looking at the difference in the frequency or the wavelength. In the ionizing radiation, we have the ultraviolet, X-ray, gamma ray for wavelengths, and for particles, we have the alpha, the beta, and the neutron particle, which are all ionizing radiation. As we discussed, there is ionizing radiation and non-ionizing radiation, and radiation is around us continually and always will be. Radiation is energy moving through space as either waves or particles. Waves move in patterns like those in the electromagnetic spectrum, which is a wavelength and a frequency, and they also move for ionization with particles. Particles travel more slowly than waves, but they still travel very fast. Examples of particles are alpha particles and beta particles. Radiation comes in the form of radiation waves and particles. In ionizing radiation, we have particles and wavelengths. Let's talk about the electromagnetic spectrum. The electromagnetic spectrum contains wavelengths which are either non-ionizing because the energy or the frequency is lower, it will not ionize an atom, and then as the frequency gets more intense or higher, we actually do have ionizing radiation. We use both ionizing and non-ionizing radiation when we do medical imaging. Non-ionizing radiation is generally considered harmless, and if used appropriately, will cause no damage to the patient. If used inappropriately, we can actually cause tissues to heat and cause some damage to the patient. Such as in MRI, we can raise the core body temperature of the patient, or in other exams where we're using infrared or microwaves, we can heat the body tissues, which could even result in blindness. But the parameters we have set for imaging are such that these are usually harmless. The one that we actually focus on is ionizing radiation, because this is the one type of radiation in this electromagnetic spectrum that has the possibility of being harmful. Not that it is harmful, but it has the possibility that it is harmful because it can ionize an atom. Ionizing atoms can cause biological harm to the body and even cancer. Take a moment to look at the electromagnetic wavelength and see the different types of wavelengths and what their uses and harms can be. Diagnostic imaging process, we require a radiation protection program. Developing and implementing a radiation protection program is a best practice for protecting workers from ionizing radiation. A radiation protection program is usually managed by a qualified expert, such as a healthcare physicist or a radiologist, who is often called a radiation safety officer, or RSO. Another best practice in a radiation protection program is designating a radiation safety committee, which includes the RSO, a management representative, and workers who work with the radiation producing equipment, radiation sources, or radioactive materials. Let's take a moment to review the components of a traditional radiation safety program. Let's take a look at the qualified staff. This would be consistent with having a radiation safety officer who is a health physicist to provide oversight and responsibility for radiation protection policies and procedures. The traditional program has a radiation safety officer included in its committee. ALARA stands for as low as reasonably achievable, and it is a guiding principle in radiation protection. We want to eliminate radiation doses that have no direct benefit to the worker or the patient. Traditional radiation safety program includes dosimetry, in which personal exposure monitoring is conducted as required by federal or state regulation for external dose and as needed for internal dose to ionizing radiation. It is sensible only to monitor those people that require monitoring and not monitor everyone who comes in contact with radiation, period. You want to monitor occupational workers. People that occasionally come in contact with radiation, such as a transporter or a nurse in the surgery department, may or may not need a radiation monitoring device. It depends on the time and the dose that they are being exposed to. Traditional radiation safety programs include surveys and area monitoring to document radiation levels, and this includes the tools required and the monitoring program software. We are looking for contamination with radioactive materials and potential exposure to workers from ionizing radiation procedures. In a traditional radiation safety program, we also need to have radiological controls on radioactive materials, including their entry and exit, the receiving of the materials, inventory control, their storage, and disposal. These policy and procedure records are integral to a good radiation safety program. Education is a key component for a traditional radiation safety program. We have education for our occupationally exposed workers, for our contemporary healthcare workers, and for the public, meaning the patient. When we talk about worker training for occupational workers, the worker training should include radiation protection, including the effects associated with ionizing radiation dose, and radiation protection procedures and controls to minimize dose and prevent contamination from ionizing radiation to both workers and the public. The primary three means of radiation protection from ionizing radiation are time, distance, and shielding. We need to know the amount of time you were exposed, how far you were away from the source, and was there any shielding between you and the source. Emergency procedures to identify and respond to radiological emergency situations are required for OSHA. Documentation or record-keeping and reporting programs are essential to a radiation safety program. We need record-keeping to maintain all records and provide reports and notifications as required by federal or state regulations. Each radiation program for radiation safety requires a minimum of one audit annually. Annually audit all aspects of the radiation protection program to update and incorporate new policies and procedures and eliminate policies and procedures that are no longer germane. Parameters for a radiation safety program can be found from publications from the Nuclear Regulatory Commission, which regulates radiation protection programs, and also from your state regulations that apply to such programs. Not only do we look to the federal and state agencies for regulation, we also look to the Atomic Energy Agency or International Atomic Energy Agency to provide guidance for medical exposure and application to exposures for both public and occupational persons. We need to be able to justify these and optimize our practices. The sources of ionizing radiation exposure include radioactive materials and radiation generating machines. As we have discussed, we use many types of radiation in medical imaging, including electromagnetic radiation and nuclear radiation. This image describes the different types of radiation that we use in medical imaging. It describes both electromagnetic waves and particle beams. Take a look at the descriptions and definitions of the use of ionizing and non-ionizing radiation that is applicable with particle beams or electromagnetic waves. Nuclear radiation refers to the particles and photons emitted during reactions that involve the nucleus of an atom. Nuclear radiation is also known as ionizing radiation. We need to know the source of the radiation, the strength of the radiation, and what type of shielding would be appropriate to minimize the impact of the radiation. This slide demonstrates 5 types of ionizing radiation: alpha particles, beta particles, positrons, gamma rays, and X-rays. It also demonstrates the penetrating power of each and the shielding required. Comparison of deterministic and stochastic health effects. What are these health effects? Deterministic sounds like the word determined, and you're right. Basically, what we're looking at is that when we use ionizing radiation, we can determine what will happen with a certain amount of radiation applied. Deterministic effects generally have a threshold dose below which the effect does not occur. So until it reaches that threshold, there is no possibility of the damage occurring to the tissue Above that threshold, there is a possibility of the damage occurring, and we know specifically what type of damage occurs at what intensity or threshold levels, which would be like radiation sickness, hair loss, etc. The greater the dose, the greater the severity of the effect. Conversely, if the ionizing radiation is below that dose threshold, the effect will not occur. Now, let's go to stochastic. Totally different. Stochastic effects are assumed to have no threshold dose. So when we talk about ionization of tissue, what we're looking at, there is no threshold dose associated with stochastic effects. Either they will happen or they will not. So previously we used the word determined for deterministic. Let's use the word probability for stochastic. So when we talk about stochastic, we're talking about the probability of something happening. Either it will happen or it will not. Take a moment to read this chart and look at the probability of developing these health effects and the severity of the health effects using ionizing radiation and alpha particles. There are a number of major theories or models about dose and ionizing radiation exposure. Here we can see 5 models looking at the dose and the relative risk of exposure of radiation to tissue. The 3 major theories or models are the linear no threshold dose, the threshold dose, and the hormetic threshold dose. Let's take a look at these. The linear no threshold dose was formulated in 1946 in response to the atomic bomb. Basically, at that time, we didn't have the instruments to measure accurately, but we could extrapolate that no amount of radiation could be safe. And unfortunately, that linear no threshold dose theory is still used today. The threshold model states that at different intensities or different amounts or dose, there is an effect. The effect increases in severity with the incremental increase of radiation. So therefore, we know if we get X amount of radiation, we could have hair loss, or we could have X amount of radiation could give us erythema, skin burn, or X amount of radiation could give us cancer. What we're looking at is not that it will give us cancer or skin burn or hair loss, but we know at that threshold it can give us cancer, burning of the skin, and hair loss. There are a number of different thresholds within this specific model, obviously. The Hormetic model is basically the same as the threshold model, except in the threshold model, what we say is there is no possibility of any damage being done to tissue at 100 millisieverts or less. And in the Hormetic model, we say, actually, some radiation dose is good for you, and we feel that that threshold should be 150 millisieverts. So basically, we're saying with the Hormetic model, anything below 100 millisieverts and 150 millisieverts of exposure, nothing is going to happen to the tissue. With the linear no threshold dose, any amount of radiation, even 1 photon of energy interacting with 1 atom, could cause biological damage. It is unfortunate that the linear no threshold dose model is still being used today. We have many, many scientific studies to debunk the linear no threshold dose model, based on the fact that we now have the technology and the information to measure smaller and smaller and smaller interactions of ionizing radiation with tissue. And we have found that below 100 millisieverts, there is absolutely no effect of ionizing radiation on tissue. Acute ionizing radiation exposure. Acute exposure overwhelms the body's natural ability to repair damage from ionizing radiation. Everything we know about radiation suggests that if you get a specific amount of radiation, ionizing radiation, at one time, it is more serious than if you get the same amount of radiation over a long time. So the idea being here is, let's take the old sunburn, suntan. When you get an acute dose of radiation, you get a sunburn, but if you only go out 5 minutes a day, you're still going to get exposed to the 2 or 3 hours total of radiation that you spent getting the sunburn, but the 5 minutes you spend each day will not result in a sunburn. That is what we talk about when we talk about acute ionizing radiation exposure. Exposure of a dose all at one time. Some things are clear. A radiation dose of 500 millisieverts using the linear threshold model is the threshold for the symptoms of radiation poisoning. Nuclear radiation refers to the particles and photons emitted during the reactions that involve the nucleus of an atom. Nuclear radiation is also known as ionizing radiation. In diagnostic medical imaging, we use both ionizing and non-ionizing radiation to create images. The difference being that the energy from ionizing radiation has the potential to cause biological damage. The energy excites the atom, and the atom emits an electron from one of its valence shells. This electron goes on to interact with nearby atoms and electrons. Therefore, there is a possibility of biological damage being done, even up to the point of creating a cancer. Radiophobia is the irrational fear of radiation. It is due to the lack of knowledge about radiation and has had a harmful impact upon the practice of medical imaging using ionizing radiation. The general public and many healthcare workers who are not associated with medical imaging or ionizing radiation have a fear of the interaction of radiation or radiophobia. Radiation is not to be feared, but it must command your respect. In other words, knowledge of the benefits or risk versus benefits is good. When we have radiophobia, we might pass up on the opportunity to get an examination using ionizing radiation that can be helpful. Very simply, you might get a chest x-ray that finds an early cancer that can be cured, as opposed to worrying about getting cancer from the chest x-ray or abdomen x-ray that you're about to receive, and not getting the x-ray and having the radiation not occur, but the cancer was there and the cancer is growing. And now you do not find out about the cancer until it's too late to do anything about it. So you can see that knowledge is power, and fear causes lots of problems in the practice of medical imaging. Misinformation about ionizing radiation has become a major problem. We have had many marketing campaigns about radiation, and we market to the public ALARA, as low as reasonably achievable, image wisely, image gently. All of this is saying that any radiation can be harmful. It is not what we are trying to promote. We are trying to promote the minimum amount of radiation to do the job correctly. If we promote radiophobia, all of a sudden we can get practices that are done in getting the exam to relieve the patient's fear, but causing the patient to get more radiation than they would have without the practice. Once a person has an emotional fear of something, it is difficult, if not impossible, to sway them from their misguided belief with any amount of science, data, or logic. So again, radiophobia, which we talked about earlier, has really been propagated by the healthcare community. A good example is everyone in the public, general public, knows from advertising that 1 in 8 women will get breast cancer in their lifetime, which is true, except the table where they got it from says 1 in 8 women will get breast cancer in their lifetime if all women live to the age of 85. And it does not say that 1 in 8 women will die from breast cancer. It simply states that you would get breast cancer if all women live to the age of 85. Two different conclusions. This is why information is very important in a radiation safety program. Let's take a look at what everybody fears about radiation and receiving a dose of radiation. Very simply, the fear is that ionizing radiation interacts with cells, and it can cause damage to the cells or genetic material. If the cells do not properly repair the damage, it will result in the death of the cell or potentially changes in the DNA, mutations, which can be cancerous. So let's take a look at this logically. I have ionizing radiation that's interacting with my body tissue. Those interactions will be repaired by my body. If the interactions are not repaired, the major probability is that those cells that were damaged will die. They will not replicate, so we have no problem there. The very small probability is that the cells will actually be damaged and mutate. And with these mutations, we're looking at something called cancer. And this happens, but over what period of time, etc. So realistically, we're looking at what can happen as opposed to what really happens and what will happen. Health effects from radiation doses can be grouped into two categories, as we talked about earlier, deterministic and stochastic. Deterministic means that we know with X amount of radiation, this is the outcome. With stochastic, it just says, with this amount of radiation, you could have a problem or you may not have a problem. It's either black or white. You did have a problem or you did not. It doesn't give us a percentage. It doesn't give us an outcome. A true understanding of the physics of ionizing radiation will help the occupational exposed worker to do a better job and also to educate their patients better. When you look at it, medical imaging using ionizing radiation exposure is actually pretty safe as long as it's done correctly. A widely used figure is that a 5% excess risk of death from cancer occurs with 1 sievert of radiation dose. Remember, dose is the amount of radiation that we get at one time. Or acute dose is the amount of radiation we get at one time. We may get several different doses that add up to 1,000 millisieverts over a period of time. Anyway, 1,000, that's a pretty good number, isn't it? So what we're looking at is, as we talked about earlier, if I have a population exposed to ionizing radiation, which will be beneficial to the outcome of their health problem, I can only up the probability by 5%, their chance of getting cancer, period, based upon the fact that they have been exposed to 1 sievert of radiation, which is 1,000 millisieverts. How much radiation is that? Well, let's see. As an occupationally exposed worker, what is the maximum dose that you can get per year? 50 millisieverts. We'll see in an upcoming slide how much radiation we do get, because we do know from each one of the exposures that we utilize in medical imaging. Basically, we used to use the term RAD, meaning radiation absorbed dose. Today, we now use the term gray, which is the absorbed dose that we get under the Systems International or the metric system as compared to the traditional system. And 100 grays equals 1 rad. Well, that's the absorbed dose, but there's also a difference between rad and rem, radiation equivalent in man. The rem, radiation equivalent in man, is also known as the sievert in the metric system, and it takes 100 sieverts to equal 1 rem. The rem is what we use to actually express biological impact. So there's a difference between the dose we receive and the impact of the dose we receive. These types of radiations are measured and have equivalencies. Take a look at the chart to the right and you can see the equivalent dose. When we discuss radiation exposure and ionizing radiation exposure to patients, we're often talking apples and oranges and different terms and different sizes or doses. What are we saying? Well, today we quantify the amount of radiation that we get from an exposure in coulombs per kilogram, which we used to quantify as a Rinkin. We quantify the absorbed dose of the ionizing radiation as a gray. We used to call that absorbed dose rad. We talk about the biological effect as sievert, but we used to call it the rem. Now, if we take the thing that is exactly the same, the sievert and the rem, or the rad and the gray, is there a difference? Well, no, there's no difference in what they are. There is a difference in how much they are. Because in the metric system, it takes 100 of the sieverts or gray to equal 1 rem or 1 rad. The metric system is far more precise because the measurements are much smaller. Well, that sounds good, but how big is big and how small is small? Well, here's an idea. Take a look at the chart that we have here and the different things that are associated with it. And we're talking about the biological effect or sievert or millisievert, and we are comparing it to different activities. If I eat a banana, I have 0.0001 millisieverts of ionizing radiation that I'm getting from that banana. Remember, ionizing radiation is all around us and even in us, because we do have potassium and other chemicals within our body. If I live 30 miles away from a nuclear plant, and in 1 year, how much radiation would I get from it? Let's see, 0.000009 millisieverts. Not a whole lot, huh? Well, let's look at something we're probably more familiar with. What would a chest CT scan? How much radiation would a patient get on average from a chest CT scan? Well, that's 5.8 millisieverts. How much radiation is that really? Well, if we compare it to the average natural background dose, in other words, the radiation we get from just walking outside we get 3.65 millisieverts per year. And with a chest X-ray scan, we get 5.8 millisieverts. Not a whole lot there, do you think? Now, if we did a whole body CT scan, we get 20 millisieverts. And the annual dose from the radiation on Monzonite Beach in Brazil is 175 millisieverts. So what we do is we try to take a look at what really exists. I mean, you're talking about the idea that eating a banana is exposing you to ionizing radiation. Are you going to stop eating bananas? Going outside and even inside, you're going to be exposed to ionizing radiation. Where are you going? There's ionizing radiation within our own system, within our own body. What are we going to do about that? So it's just able to define what is the actual terminology we're using and what does it relate to. So if we take a look again, we can take a chest X-ray is 0.02 millisieverts of radiation, which is about half the amount of radiation that you would get in a 5-hour airplane flight. Again, terminology and understanding and really putting things in perspective makes a difference when you're talking about radiation protection. So let me not be a victim of my own ranting and raving on misinformation. Let's be very precise. The sievert is what we use to calculate the biological effect of radiation dose from ionizing radiation. In radiation protection, the sievert is a derived unit of equivalent dose and effective dose. The sievert represents the equivalent biological effect of the deposit of 1 joule of gamma X-ray energy in a kilogram of human tissue. The unit of sievert is important because in radiation protection, it is the baseline we use to quantify the measurement of the exposure. How many patients actually receive more than 100 millisieverts of ionizing radiation in an acute dose or within a very short period of time during medical imaging? Occupational workers practice radiation safety and have protective equipment that they wear during the exam. So we'll look at patients. Patients, even those patients that have multiple high-dose examinations within a short period of time, rarely, if ever, exceed 100 millisieverts of radiation exposure. The greatest exposure patients will receive is usually from nuclear cardiology, a high-dose CT examination, or complex examinations for cardiology, and interventional imaging using fluoroscopy. It is extremely rare for a patient to receive more than 100 millisieverts of dose during these examinations in a short period of time. Remember, 100 millisieverts is the base or threshold for the probability of a radiation-induced cancer. It does not mean that we will have a radiation-induced cancer, but only the probability. Medical imaging, on the whole, even with multiple high-dose examinations, does not put the patient at risk with doses above 100 millisieverts in an acute dose or even multiple exams of high dose. At a range of below 10 millisieverts, which is the dose range for most medical imaging and CT studies, there is no evidence of an increased risk for cancer. It takes 100 millisieverts as a threshold dose to have a probability of a radiation-induced cancer, as we discussed earlier. The three primary methods of protecting patients and occupational workers from ionizing radiation deal with the amount of time spent near the resource, the distance from the radiation resource, and the type of shielding being used during the examination. Occupational workers generally receive very little, if any, ionizing radiation. The occupational worker works from a protected area or a control booth that limits the amount of radiation exposure that can occur. Consistent with the hierarchy of controls, PPE or lead vests and eyeglasses should only be used when appropriate engineering controls or administrative controls are infeasible. To make this very simple, the only time you really need to wear protective gear is when you're doing fluoroscopy or portable examinations, because you are not in a protective control area. This concludes the presentation of information for Section 1 of this program. We'll follow with some of the ideas or some of the concepts that you should have learned in this section prior to going on to Section 2, or the end of the program. Let's review some facts related to this first section of the program about medical imaging using low-dose ionizing radiation. There are numerous sources of regulation for ionizing radiation at the federal and state level in the United States and also at the international level. The information may differ between each regulatory agency. Radiation is formed in waves or particles. Radiation is energy moving through space. When talking about radiation used in low-dose medical imaging, there are basically two types of radiation that we look at. One is ionizing and one is non-ionizing. The non-ionizing radiation is considered harmless, and the ionizing radiation has the potential to do biological damage. We not only look at the two types of radiation that's used, but we look at the source of the radiation and the intensity of the radiation and the distance from the source. Or we look at the exposure and how that exposure is applied to the patient. The concept of dose is based upon time of exposure and strength of exposure. This concept is meaningful in ionizing radiation, as ionizing radiation can be harmful. When talking about radiation and ionizing radiation, when we talk about ionizing radiation, we need to make sure that we understand that it can be harmful to the cells or tissues that it interacts with. It does not necessarily mean that it will be harmful or there will be a biological effect. The greater the amount of radiation used and the higher the signal strength, the more probability of a biological effect happening to the patient. In most cases, the benefits of indicated medical imaging will far outweigh the relatively small excess cancer risk, and patient management should not be altered based upon radiation risk. Data provides clear evidence of radiation-induced cancer begins at doses above 100 millisieverts. A cumulative 1,000 millisieverts, or 1 sievert, would have the probability of causing a fatal cancer many years later in 5 out of every 100 persons exposed to this cumulative dose. So we're looking at an extra 5% of all patients exposed would possibly have an induced cancer. In relationship to that, we look at the maximum yearly permissible dose for an occupationally exposed worker to ionizing radiation is 50 millisieverts. This is far less than the cumulative dose of 1,000 millisieverts. The next section will cover radiation protection equipment or personal protective equipment that is outlined in the OSHA regulations. Okay, it's time for a break, time to get up and stretch, and then we'll resume in a moment with part 2 of this presentation. Ionizing radiation is ionizing radiation. What we must consider in healthcare or the medical use of ionizing radiation is the difference between low dose and high dose. Low doses of ionizing radiation are harmless and used in medical imaging, whereas in radiation therapy, where we expect to affect the tissue or even kill the tissue, we use high-dose ionizing radiation, which has a known effect at a certain dose. Let's look at dose optimization. Welcome to section 2 of the presentation. Here we will discuss more about ionizing radiation and radiation protection with a focus on the protection equipment or personal protective equipment used by occupational workers when they are exposed to ionizing radiation. The universe was created 10 to 20 billion years ago from a cosmic explosion. Radiation has existed since the beginning of the universe. Radiation is all around us, and our bodies safely absorb small amounts of natural radiation, about 8 microsieverts per day. We are constantly exposed to background radiation, and this exposure varies dependent upon where you are in the Earth at the time of exposure. Radiation. Radiation is the emission of energy as electromagnetic waves or as moving subatomic particles, especially high-energy particles which cause ionization. Let's take a look at some of the terminology associated with ionizing radiation. The first is electromagnetic spectrum. The electromagnetic spectrum is the range of frequencies of electromagnetic radiation and their respective wavelengths and photon energies. Photon. The photon is a type of elementary particle. It is the quantum of the electromagnetic field, including electromagnetic radiation, such as light and X-ray waves. The X-ray beam or spectrum. The X-ray energy spectrum is a function of primarily of the peak energy, and so is the beam quality. Now, when we talk about terms in technique, we use the term MA for milliamperage, and milliamperage is the amount of current used to generate radiation. We also use the term kVp, that is kilovolts peak, and it is the highest energy that the photons in the radiation beam can reach. The area we're most interested in is called keV, which is the average energy of the photon beam. So when we compare kVp and keV, keV is the average energy in the beam, and kVp is the peak or the highest energy in the beam. When we discuss radiation protection and radiation dose, we talk about quantities in what are referred to as SI units, or the System International units. The first is absorbed dose. That is energy absorbed by the irradiated sample of matter. It's a physical quantity. The next is equivalent dose. That is the biological effect of the radiation type that is used to interact with the tissues. Multiple radiation types require calculation, for each of which there are different summations. We would use a different type or amount of radiation for the hand than we would for the thorax as far as the technique or the quantity and amount of radiation to visualize the areas of interest. And last is effective dose. In effective dose, what we're talking about is the biological effect on tissues, and this biological effect has a weighting factor. So in other words, each tissue has a weighting factor that correlates to its sensitivity to radiation. Just to recap, we are talking about low-dose ionizing radiation utilized in medical imaging. At low doses, radiation risk is simply associated with somatic effects, to include cancer. Conclusive evidence of radiation effects is lacking below a total of about 5,000 to 10,000 millirems of exposure. Ionizing radiation exposure effects. We are looking at two main areas: teratogenic effects and somatic effects. Teratogenic effects are the effects of ionizing radiation on offspring while in utero. The majority of what we look at in focus on this program is on the somatic effect, which can either be prompt or delayed. The somatic effect has two types of effects in the exposure. The first effect is a stochastic effect, which would be the probability of getting a radiation-induced cancer. The second effect would be a deterministic effect, which is a specific exposure will cause the probability of a specific biological response. The most precarious time for a fetus to suffer negative effects of ionizing radiation are weeks 8 through 15 of gestation, when its organs and nervous systems are forming. Severe issues have a higher possibility of occurring with exposures of 1 to 2 sieverts of radiation, but research has shown that defects can occur at levels as low as 100 to 200 millisieverts. The risk of developing childhood cancer is highest if the fetus is exposed to 200 to 250 millisieverts of ionizing radiation between weeks 2 and 15, while more than 100 millisieverts of radiation can increase the frequency of childhood cancer, cause small head sizes, cause seizure, and reduce IQ. To date, there is no evidence of genetically heritable risk in humans from exposure to ionizing X-ray. Sieverts and REM are just two of the many units you may see associated with radiation levels. Scientists use different terms to describe radiation depending on where it is and what it's doing at the time of measurement. Let's clarify the terminology on the radiation effects on humans one more time. We have an international standard that is used using a metric system, which is sieverts and grays and the amount of radiation per coulomb. We have a traditional system, which was the Curie, the Rinkin, the rad, and the REM. Traditionally, the REM was equivalent radiation in man, and that is the quantity of ionizing radiation whose biological effect is equal to that produced by 1 Rinkin of X-rays. Reflecting this amount of radiation, we also have the absorbed dose. Again, the quantity of ionizing radiation whose biological effect is equal to that produced by 1 Rinkin of X-rays. So the idea is one is absorbed dose and the other is the actual effect of the dose. So when we talk about radiation protection, we are primarily interested in the effect of the dose on human beings. In the 1800s, we utilized the traditional system to categorize radiation. We used the Curie, the rad, the REM, and the Rinkin to describe ionizing radiation and how it is utilized. Today, we use system of units, which is an international measurement of systems, and it is a metric system. It allows us to quantify the radiation in much smaller and more accurate definition. To give an example, a basic unit such as a rad, which would be the absorbed dose of radiation, can be broken down into 100 grays. So we have more definition when we use the terms from gray, or the measurements in gray, than we have in rad, because the rad is simply just a large dose. Here we can see a chart of dose. And what we're looking at here is the fact that there is a substantial and convincing scientific evidence for the risk of exposure to high-dose radiation. Remember, in medical imaging, we're using low-dose radiation. Below 10 REMs, or 1,000 sieverts, which includes occupational and environmental exposures, risks of health effects are either too small to be observed or are non-existent. Because radiographers or medical imaging specialists are usually the first and often only medical professional to interact with patients who are receiving a medical imaging examination, they are charged with a great deal of responsibility even before the examination begins. Being able to expose patients to ionizing radiation, the worker must be responsible. They must work in a safe manner, comply with radiation protection regulations, and report any unsafe procedures that occur. Modality operators need to know what is expected of them, especially if the modality generates ionizing radiation. Vendor applications training is never sufficient because the training only applies to the operation of the equipment. When we think of the ionizing radiation produced by the equipment and its impact upon the patient, we need to implement local policies and procedures for radiation safety. Clinical competency criteria are helpful for standardizing and documenting basic proficiency in training for both the clinical operations and radiation safety aspect of the modality. The operator of the modality is responsible for the exposure technique, which is the different parameters that are chosen to create the ionizing radiation or non-ionizing radiation exposure that will be used in creating a medical image. ALARA is an acronym for as low as reasonably achievable, which means every reasonable effort to maintain exposures to ionizing radiation should be made to keep the ionizing radiation minimal for the study. The primary tenets of radiation safety consist of ionizing radiation controlling the distance, controlling the time, and controlling the shielding of the primary beam. How do you ensure ALARA with the digital imaging receptor you have now? Very simply, you need to really understand exposure, technique, and your equipment. In the beginning of medical imaging, the images were created with analog signal. That has evolved, and today the images are created with digital signals. The ionizing radiation creates a signal, and this signal has a wide range to it. There are portions of the signal that we do not use in medical imaging, and what we look at is the portion that we do use within the medical imaging parameter, and this is called dynamic range. The dynamic range of exposure for an analog signal is different from the dynamic range of exposure for a digital signal. When we create images, the image receptor type and how we process the image makes a difference. This means that we have to use a different type of exposure for medical imaging when we use an analog system than we do for a digital-based system. Therefore, the techniques or the parameters utilized to create the exposure differ between film screen, which is analog, and digital exposures, which is the computer-generated images that we use today. The dynamic range of digitally acquired images is far superior to the images acquired using the analog or film screen system. The difference being that we have a wide range of choices for the shades of gray or dynamic range based on how we assign the digital intensity of a specific capture. Modality operators must understand the physics of technique for digital imaging and the type of image receptor that their ionizing radiation is coupled to. Here we see some of the components that are utilized in creating an exposure. The most important part of creating an exposure is understanding the anatomical area that we're looking at and what we are trying to display. Using all of the information that you have, you can create an exposure profile that will produce the most information for diagnosis. In traditional analog imaging or film screen, the exposure resulted in a specific output. Today's imaging is digital, and in electronic imaging, the functional parts of a conventional radiology have been separated into image capture, image storage, and image display. And we can manipulate each of these areas to produce an image that we would want to display for a particular reason. What are we looking at here? In other words, we create the digital image from data. We can manipulate that data to display any way that we wish. But this takes a greater knowledge of anatomy, physiology, and what the physician is specifically looking for, and coupling that with your technical expertise as a modality operator. When we use low-dose ionizing radiation, we create a primary beam. The primary beam is the ionizing radiation which interacts with the patient. An occupational worker should never be in the primary beam. The primary beam affects the radiation dose to the worker, and the remnant radiation that is emitted from the patient determines the amount of dose to the operator. Attenuation of X-rays in solids takes place by different mechanisms, some due to absorption, others due to the scattering of the beam. Differential absorption is based upon both the thickness and composition of the object being X-rayed. The remnant radiation forms a latent image. Absorption characteristics of materials are important in the development of contrast to visualize the image. In formulating exposure techniques, differential absorption is a primary factor. Although two patients may measure the same, factors such as pathology, muscle, gas, fluids, etc. should be incorporated into creating the exposure technique, because these factors affect the differential absorption of the ionizing radiation. The amount of ionizing radiation that an occupationally exposed worker is exposed to needs to be put in perspective. The exposure to the healthcare workers from ionizing radiation is not emitted from the primary beam, but from the remnant radiation emitted from the patient. It has been calculated using the inverse square law that the remnant radiation exiting the patient drops to approximately 1/100th the entrance dose at 1 meter from the patient. Radiation that the occupational worker is exposed to is then 0.1% of the intensity of the primary beam that enters the patient. In other words, if we are using ALARA as low as reasonably achievable to expose the patient, we're using the least amount of radiation. And once that radiation is absorbed by the patient, a very, very small percentage exits the patient, and this small percentage is the type of radiation that the occupational worker would be exposed to in medical imaging. To protect the occupational worker from the cumulative dose of radiation that they receive over a 1-year period, we use PPE, or personal protective equipment, such as lead vests, lead shields, etc. Remember, we are only protecting the worker from the radiation that is emitted from the patient. So let's take a practical example. If the radiation emitted from the patient is 1/1000th the amount of radiation that is in the primary beam at 1 meter distance from the patient, and we are wearing a lead protective apron or a protective apron that absorbs or blocks 99% of the dose, how much radiation are we actually receiving during the exposure? When the primary beam interacts with the patient, how much radiation does the patient absorb? The probability of interaction with matter depends on several things. First, the initial energy of the photon. This would be the energy or speed, the keV. EV being electron volts, K, 1,000 electron volts is how we move the energy. That energy then must enter the patient, where there are different thicknesses and different atomic numbers that affect the absorption properties. The amount of photons available from the tube for ionizing radiation and the modality used have a major influence on the technique selected. Anatomical information from the varied interaction across the anatomy, which is interpreted by the vendor-specific software programs, is how we display the information that we have chosen to display. All low-dose medical images are acquired from recording energy interactions. The data captured on the image receptor is a reflection of the tissue at a specific point in time. That data can be post-processed to create different types of images. We can also reuse the data at a later date and manipulate the data again to create a different type of image. As long as the data is in storage, we have the original interaction, and we can look at that interaction in many ways. The modality operator selects the technical factors utilized in creating the exposure. The technical factor selection differs for analog versus electronic imaging or film screen versus digital. The radiation still stays the same. We have the photoelectric effect, we have Raman, and we have scatter radiation that is being recorded. The contrast in an image is produced by the objects and the attenuation of the X-ray or ionizing radiation that is interacting with the tissue. The operator of the modality creates the ionizing radiation parameters that are used in the exposure. The majority of energy captured on the image receptor is scatter radiation. It is only Raman and the photoelectric effect that are useful in creating different shades of gray or different densities that correlate to the tissues that they interact with. Three primary methods of reducing the amount of exposure. The amount of exposure received can be reduced through time, distance, and shielding. Time relates to the amount or dose of exposure that is directly related to the length of time the ionizing radiation occurs. Distance from the source of the ionizing radiation is directly proportional to the intensity of the distance. This is calculated using the inverse square law. The farther the distance from the source, the less the intensity of the radiation. Shielding is a physical barrier designed to provide protection from the effects of ionizing radiation. The strength of the ionizing radiation in its intensity and amount has an effect on the amount of shielding required. Radiation programs require documentation of the shielding, where the shielding is located, and as to the condition of the shielding. Therefore, the shielding must be inspected in the radiation safety program. This documentation is part of the quality assurance program, and there must be standardized policies and procedures performed by the staff assigned to maintaining the documentation for the program. The federal government of the United States has a total effective dose limit, which is a summation of the external weighted and internal doses averaged out. So basically, with the total effective dose limit, the occupational worker is limited to 5,000 millirems per year. That's total effective, but individual organs have different sensitivities. And so what we look at is the individual organ limit is 50,000 millirems per year. The lens of the eye is more sensitive than the organs, so that is 15,000 millirems per year. And the skin, hands, and single organs are about the same as an individual organ limit, so again we have 50,000 millirems per year. 50,000 millirems is 50 millisieverts per year. Personal protective equipment is widely used throughout the healthcare system. The radiation protection materials such as lead vests, lead gloves, thyroid shields and eyeglasses, and shields for ionizing radiation make up one portion of the PPE, or personal protection equipment. Surprisingly, the documentation on this is very poor. Few hospitals fully understand the value of their inventory or how to make the best use of it. For example, how much does a lead vest cost, and how many do you have in your hospital? How much does a thyroid shield cost, and how many do you have? Without knowing that, we often have hundreds of thousands of dollars worth of inventory that we're not taking care of because we really don't know the value. Understanding the value of your PPE will help you to maintain better documentation, and also with the better documentation, better care of the individual pieces. Joint Commission and OSHA require documentation and inspection of personal protective equipment that deals with ionizing radiation. Remember, the items we use for personal protection against ionizing radiation are only one part of the personal protective equipment that is available throughout the healthcare system. What is the definition of personal protective equipment? The definition is devices used to protect an employee from an injury or resulting illness from contact with chemical, radiological, physical, electrical, mechanical, or other workspace hazards. Let's do a little refresher on your radiation biology knowledge, and we'll take a look at a few random facts that have to do with ionizing radiation and occupational exposure. The first being that 50 millisieverts per year is a maximum permissible dose for occupationally exposed workers in ionizing radiation. Why was 50 millisieverts per year chosen? The reason for this very simply is that ionizing radiation, even an acute dose of 100 or more millisieverts, is required for there to be any biological effect. Another fact about radiation is that the dose that produces twice the natural radiation-induced mutations in cells is about 7,000 millisieverts. We can also look at the effect of ionizing radiation on a fetus. A fetus receiving less than 1,000 millisieverts should be perfectly safe and have no biological effects on them as a child. Above 2,500 millisieverts is only the probability of their having a biological effect on the child. Ionizing doses of radiation affect the cells and tissue and also in the blood. Doses in excess of 2,500 millisieverts are required to produce the first changes seen in any cell, period, and that is a decrease in the white blood cells. And this dose must be delivered all in one day, not protracted out over a year, because the cells will recover and repair. So it needs to be an acute dose within one day. A final fact that would be interesting to most people is that low exposure to ionizing radiation actually decreases the level of probability of having a cancer. This phenomenon is called hormesis and is a scientific fact. Misunderstanding or misinformation about ionizing radiation and its biological effect has been around for years. Most people believe any radiation and any exposure to radiation can cause a biological effect, and this is simply not true. To the point that we were doing things to protect patients from very low doses of radiation that actually increased the amount of radiation that was required to produce the procedure. To date, there is no evidence of genetically heritable risk in humans from X-ray exposure. Under some rare circumstances, if you have prolonged high dose exposure, remember we're talking high dose exposure, such as radiation therapy, X-rays can cause other adverse health effects such as skin erythema or reddening, skin tissue injury, and birth defects in utero exposure. We are using low dose radiation when we are doing medical imaging. But at the exposure levels associated with most medical imaging procedures, including CT, those adverse effects do not occur. Internal dose weighting factors. Well, what are we talking about when we talk about internal dose weighting factors? What we're talking about is as you get an exposure of X-ray to your whole body, there are certain portions of your body that are more sensitive to ionizing radiation than others. So each exposure would be a total exposure of 1, and the relative sensitivity of the radiation would be the weighting factor. So if my total body sensitivity is 1, my weighting factor for the gonads would be 0.25. In other words, that would be the sensitivity. My weighting factor for the organs would be 30. For the red bone, lung, thyroid, bone tissue, and other surfaces, we would have different weighting factors as well. We would take and add all these weighting factors together to total 1. And that 1 is the radiation exposure that we received. Not all personal protective equipment apparel used for worker safety when the worker is exposed to ionizing radiation is equal. In other words, it's not the same. It varies from manufacturer to manufacturer, and it also varies from the type of vest that you have, or the type of glove that you have, or any other type of shielding equipment that you might wear by design. You need to understand all this when you purchase this equipment because it's very expensive. You also need to understand how it is designed because we have non-leaded and leaded radiation protection apparel available and how to take care of it. Totally different in how this is done. So we're going to take a little review here on apparel and equipment used for ionizing radiation protection. There are many types of shielding from ionizing radiation. The one that is most universally known is the lead vest. Of course, today we have lead and non-lead vests, and we have a myriad of different types of radiation protection devices that are manufactured by different manufacturers. Each has its own unique protection capability. How much radiation protection equipment do I need? And how much do I actually have, and of what use is the equipment? How do I actually utilize it and take care of it? We're going to look at some of the QA factors that differentiate different PPE apparel. One of the first factors that most people are interested in, of course, is the protective type of material used for the apparel, its quality, and the weight. What is the comfort and use of each piece? What is the design based upon? What application? Are there differences in apparel for men and for women and children? What are the covering fabrics and how suitable are they for maintaining a sterile environment? And what is the workmanship and consistency in each piece? This will vary by manufacturer and vendor and needs to be looked at very closely. The common term for the aprons that are worn by occupational workers when using ionizing radiation is lead aprons. That is because lead was the first material that we used as a shielding for ionizing radiation. And we also use lead as the basis for comparing other materials and how they absorb or shield us from the radiation. We have leaded and non-leaded. In fact, there are basically 3 common types of lead aprons. There is the full lead apron, which is made of lead and is the heaviest. There is a lead composite, which again uses lead mixed with other lighter materials. And there is non-lead, which we look at the attenuation factors of the materials that are used in constructing the apron to compare it to the lead aprons. The point being is the factor that makes a difference here is the malleability of the material and the weight of the material. We have 3 types of material that we utilize to make protective apparel. The first would be lead. The second would be a lead composite or a lead powder mixed with other materials. And the third would be no lead. Remember, lead was the very first material we used for shielding. When we use no lead, we use materials that have the efficiency or high atomic number similar to lead to block the ionizing radiation. So lead is the benchmark. The problem with lead is it's heavy. It is easier to wear a no lead vest than a lead vest for 7 or 8 hours. The weight of the actual apparel can cause physical damage over a period of time, such as back problems. What about lead material? The first thing is that lead is the traditional material that is used for shielding, and we use it as a calibration for all other materials. Now, let's look at it realistically. When should I wear radiation protective gear? Should I wear it when I'm doing a CT scan? Should I wear it when I'm doing a bone densitometry scan? Should I wear it when I'm doing ultrasound? Should I wear the lead vest or materials when I'm doing interventional radiography and fluoroscopy? Should I wear them when I'm doing portable radiography? All of these situations are different and all require different types and styles of lead vests. If I'm doing bone densitometry, the emission from the patient is so low that I do not need to wear a lead vest for protection. If I'm in a room, a control room, operating my equipment, the control room, such as a CT scanner, is already shielded. I don't need to wear a lead vest. If I'm working as a radiographer doing portables, I only need to wear protective shielding when I come in contact to do the patient and there is no other shielding available. So I would only wear the shielding infrequently. Conversely, when I'm doing interventional fluoroscopy, all of my patients are going to be emitting radiation and all of my patients are going to have long exposures. So I really don't need a lead vest for doing bone densitometry, CT, or any other type of study that has radiation that cannot affect me. I do need to wear it when I'm around ionizing radiation for portables and fluoroscopy. For the portables, I am using a lead vest infrequently, and it does not have to have as much protection as the fluoroscopic vest because I have the ability to stand farther away from the patient and use the inverse square law. So the farther away I'm standing, the weaker the radiation. Conversely, I need the most protection if I'm doing, say, fluoroscopy, interventional cardiography, or interventional studies with fluoroscopy. I'm going to be near the patient. They are going to be emitting radiation and over long periods of time because that is what I'm going to be doing all day. So would I need a different type of lead vest or a different quality lead vest? Because I can't just back out of the room while I'm trying to work on the patient. I've got to be near the patient. So now the inverse square law is working against me. Lead is an absorber of ionizing radiation, and we use it as a shield. It has a high atomic number. We also use lead equivalency materials. In other words, materials that also have high atomic numbers equivalent to lead for shielding. Various thicknesses of pure lead provide different levels of protection, and various thicknesses of the non-lead and composite lead shielding provide equivalent protection as well. So what are we really looking at when we're talking about radiation protection? Well, we have to think about where we're using the radiation protection, how many times we're being exposed, or what is the rate of exposure that we're going to have, and what is the type of exposure we're going to have. It would make a big difference in our choice of apparel. So here we have a list comparison of protection provided by lead thicknesses when the X-ray machine is set at 80 kVp. Remember, kVp is the highest energy that the electron photon in the ionizing radiation beam can go. Does it mean all the photons are that? No, it means there are very few, if any. That is the highest energy that it can be. The average, or KeV, is about 2/3 of what the kVp is. So again, kVp is talking about the highest energy for protection, and we always want to look at the most protection we need. So when we talk about protection, we talk about the absorption protection and the thickness of the material. So if we had 1 millimeter of lead, or we had 0.01 millimeters of lead, would there be a difference in the radiation protection? Yes, there would. The thickness at 0.01 millimeters of lead will only absorb about 25% of the kVp, highest energy, radiation and below of the ionizing beam. In using the same beam, if I wore a 1 millimeter thick lead vest, it would gather and protect me from more than 99% of the radiation. Well, obviously I need the one. No, you don't, because what you're looking at is there's a trade-off between weight, thickness, and protection. You only need the protection for the ionizing radiation that you are going to be exposed to. And remember, that ionizing radiation comes or is emitted from the patient. It matters the distance from the patient for the inverse square law. So choose your vest or radiation apparel according to its actual need and the use that is being used for. You don't go out and shoot a rabbit with an elephant gun, and you don't shoot an elephant with a BB gun. Think about it. Given a choice based upon the weight of the material and how long you wear the material, the obvious choice would be to choose non-leaded material every time, because the non-leaded material absorbs the same amount of radiation as the lead, and also it's lighter. We also need to take this in consideration when we think about the weight, the thickness. The thicker the lead, the heavier the lead. The thicker the non-lead, the heavier the non-lead. So those combinations of weight and thickness make a difference when we choose our apparel. Another factor would be how close are we going to be to the source of ionizing radiation. Remember, the ionizing radiation would be emitted by the patient. And if I had 2 lead vests with the exact same amount of penetration protection, and one cost $50 and one cost $1,000. Let's say the $50 vest was a lead vest and the $1,000 vest was the non-lead vest. Now, would that make a difference on my choice of which one I would wear? In which situation? You bet. If I'm going to wear the leaded vest, I am probably going to wear it during a portable radiograph, because I am bringing the X-ray equipment up to the patient's bedside and I'm doing point of care. which means that there are going to be long intervals in between, a very few amounts of exposure, and those exposures will generally be less than 100 kVp, so they're not going to be as penetrating. Therefore, the radiation being emitted from the patient is not going to be as penetrating, and I can move back at least 6 feet or 3 feet minimum, but I can move back using the inverse square law to where the factor is almost zero that I will get any sort of radiation exposure whatsoever. On the other hand, if I'm working in interventional cardiology fluoroscopic suite, I'm going to be wearing the vest almost all day, and it's going to be much lighter, and I'm not going to be able to step away from the patient. I'm going to be right next to that patient most of the day. In that case, I think I'd choose the non-lead material. As you can see, there are a lot of different factors that go into choosing the radiation safety apparel. We've talked about the weight factor and the use factor, but there is another factor to consider. With a lead or lead composite vest, when you dispose of the vest, you must document its disposal. You do not need to document a lead-free or composite vest because the material is not toxic. So there are a number of things that you have to look at when you choose your radiation safety apparel. First is the function of the safety material, where you're using it, how you're using it, and why you're using it. Next, obviously, would be the weight of the material. Next would be the cost of the material. And the next factor would be how do we dispose of the material once we're used it. The idea being here that there are a lot of different factors to look at and weigh when making a decision on what type of apparel to buy, because the apparel is basically the same. Quality assurance and quality control need to be applied to all PPE materials. Radiation safety is the issue. We need to be able to manage these materials as far as knowing where they are and in what shape they are. And we have guidelines put out by local, state regulators and also Joint Commission that you can use to create these quality control procedures. Well, when you're doing quality control, you need to have guidelines as to what you're looking for. So here we're going to give you some do's and don'ts. You do inspect and check aprons for defects. You do clean the apron regularly because remember, we're in a hospital environment and we want to make sure that we have infection control procedures to keep us from getting infected as an occupational worker and from keeping others infected by the PPE, which may serve as a vector for the transmission of different types of viruses, etc. We do want to follow the manufacturer's recommendations for storage and care of the apron or the PPE. We do want to dispose of any toxic materials properly. As in all things, there's always a yes and no, or maybe, could be, and that is especially true when we're doing inspection of our lead aprons or PPE materials. Currently, there are no standards establishing a criteria for the acceptance or rejection of lead aprons. We are inspecting the lead aprons, but again, there is no criteria for acceptance or rejection of lead aprons. Because people have radiophobia and they're scared of radiation, we may throw a perfectly good lead apron away because it has a small crack or defect or tear. On the other hand, what is the amount of efficiency that you have detracted from that entire barrier with the small crack, deficiency, or tear? That's where the subjective knowledge comes in handy on whether we keep it, repair it, or dispose of it. Aprons can fail inspection testing for many reasons. The following are the most common examples. Take a moment to read through the differential between holes, cracks, and repair and damage to the apron and see what you think. Remove lead aprons that do not pass physical inspection for use. Then you may either have the apron repaired or you may discard it. When you discard the lead apron, it makes a difference whether it is a lead apron, which is a toxic material, or a non-lead apron, which is a non-toxic material. Lead is a biohazard, and documentation is essential on the disposal of lead aprons. One of the biggest problems with quality control, quality assurance, and all the documentation and the we care better is that we have all of the good intentions, but we often fail to do things because we'd rather have the patient throughput. If I assigned a tech working for me as a quality assurance, quality control tech who was a good CT tech, it would not be long before that tech is behind the console on the CT scan and the duties of quality control and quality assurance had been left behind. This seems to be the rule rather than the exception to the rule. Typically, a hospital takes 2 to 4 weeks to inspect all of its aprons, assuming an average of 500 to 1,000 aprons on site, and that is just the aprons. When doing inventory inspection, you must provide an accurate record for regulatory documentation and much more. So what's the difference in wearing PPE apparel and renting bowling shoes? Bowling rental shoes are cleaned and disinfected after every use. I did a survey at one of my hospitals, and what I found was that the lead aprons in surgery, in interventional, all throughout the hospital woefully needed cleaning and had not been cleaned, and in many times people cannot remember when they were last cleaned. And yet the hospital is one of the dirtiest places to be when you're a patient or a healthcare worker as far as infections and different types of things such as MRSA, etc. go. How often do you clean your equipment and how well do you store it? When we're talking about protection from PPE, we're talking about more than just radiation protection. The radiation protection equipment or shielding needs to be cleaned and disinfected and taken care of correctly so that we do not contaminate ourselves because of the working environment in a hospital. As you look at the regulations and the policies and procedures that should be and that are designated to be by several of the different regulation agencies such as CDC, JCHO, AORN, AP, all of them have rules and regulations and suggestions for cleaning and sanitizing programs that are in accordance with the governing bodies such as Joint Commission. We do not want our protective equipment to become a hazard for bloodborne pathogens and other bacteria and microbes a vector for infection in the hospital. They need to be cleaned and taken care of correctly. During your manual inspection and required inspection by both Joint Commission and other regulatory agencies of your PPE, you'll find that when surveying people that work in the area, that the PPE has not been cleaned or has sometimes been cleaned. In addition to that, the next thing you may find is that even if the staff makes an effort to clean correctly, they may not do the process right, and this causes a lack of efficiency and wasted effort. You must follow proper policy and procedures in cleaning the materials as well as the timing of cleaning the materials. Cleaning and sanitizing of a neglected surface such as a lead apron cannot be accomplished in one step either. To address such biofilms adhering to PPE and to clean them away, hospital systems and healthcare providers that do not use apron servicing companies are implementing multi-step cleaning and sanitation programs for X-ray aprons and lead wearables. Cleaning programs require more than just simply using a sanitizing wipe. There is a multi-step cleaning process for lead aprons and gowns. When facilities only use wipes on a surface and don't completely remove the debris, they are in essence creating an all-you-can-eat buffet for the surviving bacteria to thrive upon. In fact, numerous studies have shown that certain bacteria can pick up various genes from different species that makes them more pathogenic, either by making it antibiotic resistant or antiseptic resistant, or by allowing it to survive after the wipe has gone over it. We should be cleaning the entire environment, including the PPE. Unfortunately, when it comes to medical devices or any surface, particularly a porous or textured surface in a medical treatment facility, such as lead wearables, biofilms can form once the surface is exposed to organic matter, such as blood. Now, with the mental picture of layers of bacteria, such as plaque, on surfaces in medical treatment facilities, consider that some of the high-touch surfaces, such as radiological shields and aprons, have not been cleaned for years, if ever. Cleaning is the removal of foreign material. An example would be soil and organic material from objects and is normally accomplished using water with detergents or enzymatic products. Thorough cleaning is required before high-level disinfection because inorganic and organic materials that remain on the surfaces of the apparel interfere with the effectiveness of these processes. According to regulatory agencies, such as the Department of Health and Human Services for the United States, the Center for Disease Control and Prevention in the United States, and Joint Commission, X-ray aprons and lead wearables can no longer be overlooked, and they will need a renewed commitment to servicing. They need to be properly cleaned prior to sanitation efforts, in accordance with the guidelines of the CDC and the Joint Commission. Let's now see how occupational workers put ALARA into practice and practice time, distance, and shielding to minimize the radiation dose to patients. Special care is taken during X-ray examination to use the lowest radiation dose possible while producing the best images for evaluation. National and international radiation protection organizations continually review and update the techniques and standards used by radiology professionals. Modern X-ray systems have very controlled X-ray beams and dose control methods to minimize scatter radiation. This ensures that those parts of the body not being imaged receive minimal radiation exposure of a radiation safety program. There are three major areas to begin with. To make every reasonable effort to maintain radiation safety using ionizing radiation exposures that are as low as reasonably achievable. To ensure that all exposures are made in compliance with all laws covering the use of such materials, machines, and devices that produce ionizing radiation. And to monitor radiation exposure of healthcare workers in the facility utilizing the equipment. We'll now take a look at the monitoring portion of the Radiation Safety Program. The Radiation Safety Program is headed by the RSO, Radiation Safety Officer. The Radiation Safety Officer is a person designated by the facility to be responsible for radiation safety in the facility. This person should be a physician or a physicist, or at last resort a radiologic technologist. Responsibilities for the RSO include assuring compliance with policy, procedures, and regulatory requirements, developing a radiation safety program for the facility, and monitoring of workers, ordering dosimeters, checking dosimetry reports, and communicating dosimetry reports. So, how big are the risks today for occupational exposure for people working in medical imaging? The actual answer to that is not very high due to the radiation safety programs that we implement and utilize. Since medical personnel who are exposed to ionizing radiation that is frequent enough or high enough in dose, they should be monitored. Many medical professionals may perform large numbers of X-ray procedures every year. They may wear lead aprons and PPE to protect themselves from radiation. Usually, medical staff also wear tags or dosimeters which monitor their overall level of radiation exposure, and these tags are periodically read to ensure that the staff are not at risk of injury or illness. Lead vests and radiation monitors are not required for those that use ionizing radiation equipment such as bone density scanners, which put out a minuscule amount of radiation dose, but they should be very aware of radiation safety policies and procedures. What's a control badge? Well, a control badge is a radiation dosimeter that is used for monitoring the other dosimeters which people wear. In other words, it's set up as a control. It's stored in an area which will not receive any radiation exposure and where the other badges are stored when not being worn. It is used to mail the dosimeters back for processing and take that badge as the basis for comparison to the ionizing exposure of the badges that are mailed in for checking. It will reflect any exposure to the badges above normal radiography. There are different types of monitoring devices that are used in the radiation safety program, but all of the dosimetry devices must be in an area that has no ionizing radiation, and a control badge is utilized to act as a baseline for the amount of radiation that may have come from background radiation in the area. Commonly in medical imaging, two badges are worn. For most techs, they will wear a normal dosimetry badge. For nuclear medicine techs who work up different procedures using ionizing radiation as a radionuclide, they will wear a ring badge as well because they are holding the radionuclide in a syringe in their hand. So we measure the amount of radiation that goes to the ring badge as well as the amount of whole body radiation that goes to the dosimeter on the chest. When reading the dosimetry badges, we only want to read the ionizing radiation that you've been directly exposed to. This is why the badges are kept in an area where there is no radiation exposure when the occupational worker is not wearing them. If the occupational worker does not take care of their badge correctly and they do something that damages or changes the readings in the dosimeter, they are not accurate. So we should be careful not to leave your dosimeter in your car in high temperatures. Wash and or dry your dosimeter in the laundry by accident, or leave your dosimeter on top of your television or microwave oven, which also generate ionizing radiation. Dosimeter reports. At a set time parameter, the dosimeters are mailed to the processing center for analysis. The control badge is mailed with the dosimeters in the same envelope. You'll receive a dosimeter report back from the center after they have been read. Occupational personnel need to review their dosimetry reports. Radiation workers should be given access to the dosimeter reports. These must be made available without privileged information visible to the whole facility staff, things like date of birth and social security numbers. Workers should initial the report notifying the RSO that they have seen and understand the results. We've talked about monitoring the occupational worker, but what happens when the worker becomes pregnant? Are there pregnancy issues? Yes, they are. The pregnant technologist is different from the fetus. And there is a difference between a potentially pregnant technologist and an undeclared pregnancy. So we'll review some of these pregnancy issues to have a better understanding of how to monitor them. From a medical legal standpoint, you cannot assume that a staff employee is pregnant. The pregnant occupational worker must declare the pregnancy in writing before you can address the pregnancy and monitor the pregnancy. In addressing the pregnancy, you might explore the potential to remove the technologist from some of their duties for at least the first trimester of the pregnancy. It is inappropriate to increase the radiation exposure of another worker in response to the pregnancy of another technologist, though. Once the worker declares their pregnancy, we need to create a file documenting the employee's written declaration of pregnancy. We need to secure a letter from the employee's physician documenting their estimated date of conception and delivery, and that the physician clears the employee to work in a radiation-related area. We need to order an additional personnel monitoring device to be worn at the level of the waist and underneath the lead vest or lead apron, because this monitor is monitoring the radiation dose that the fetus receives and not the radiation worker. The radiation worker wears their dosimetry badge, as you remember, outside of the lead apron so that we can monitor the whole body radiation that they've been exposed to. The regular personnel monitoring device will continue to be worn at the level of the collar. Medical legally, the pregnant technologist becomes pregnant when she declares she is pregnant. She will have the option of declaring her pregnancy to the supervisor of the facility. The pregnancy must be declared in writing to the facility and appropriate measures taken related to the pregnancy once it is declared. To monitor the ionizing radiation that the fetus may receive, a second dosimeter is worn underneath the lead vest or lead apron at the level of the waist near the fetus, so we can get an idea of how much actual ionizing radiation has occurred at this area. As a pregnant occupational worker, do not switch the location of your dosimetry badge to the fetal monitoring position. You need two badges, One is for you, whole body, and one is for the fetus. The fetal badge, as we have said, is worn underneath the lead apron at waist level. If you have any procedures done using ionizing radiation as a patient, you should wear your fetal dosimeter when having those exams done, and they should not count towards your occupational exposure, but the exposure of the fetus. Take a couple minutes to study this graphic. It demonstrates exposure measured in millisieverts. Remember, this is for biological damage, and it gives a comparison to the amounts of radiation exposure. It then gives you a chart which shows you different types of medical imaging exams that patients may receive and the average effective dose that the patient receives for this exam. As the final slide appears, I'd like to thank you for your patience and hope you enjoyed the presentation and got some information that is worthwhile. We're going to take one last look at dose. Whole body dose is 50 millisieverts, which is 5,000 rems per year. If we were looking at a single organ, any single organ, there is a difference in the sensitivity. And that specific organ dose can be 50,000 millirems. The eye is more sensitive than any single organ, and you can get 15,000 millirems of exposure to the eye. That's for occupational limits. How about members of the public? Members of the public should receive no greater than 100 millirems per year in radiation unless it is warranted for their diagnosis and treatment. No more than 2 millirems in any 1 hour in an unrestricted area from an external source is allowed for areas in which the public may be sitting or residing. Remember, we have occupational workers get a declared pregnancy. They are not pregnant until they declare their pregnancy. For the declared pregnant occupational worker, they're allowed 500 millirems per term, term being the term of the pregnancy, and it is evenly distributed. Thank you again, and I hope this is of help.